Welcome everybody, welcome. You are in the right place if you want to learn more about CRC, the CRC credential and being a certified risk adjustment coder. I have experts with us, and the topic of today's webinar is the top 9 questions every medical coder asks about risk adjustment and the CRC certification. And we welcome you for being with us here today.
One of the things that's important to know about risk adjustment is, why we do risk adjustment and why it started, the history of risk adjustment. So if you kind of know that, then it gives you a better understanding of why you do what you do. Also, is there really a demand for risk adjustment? Now, if you hear me talk about it, it's something I'm passionate about, but I'm very biased because I love to do it. And you don't want to just go by what I say because, again, I'm biased. But there is truly a buzz, and you don't just hear it from me or CCO. It's because of what's happening out in the medical arena right now. And does the CRC certification give you a higher salary? We're going to talk about that. What about making you more employable? Having the CRC, how does that change your ability to become employed? The CRC is the designation only include HCC risk adjustment coding, only Medicare. We're going to answer some questions about that. Is RA seasonal coding? I hear this a lot, and we're going to answer that question. Do you need to be a CPC first? Now, Chandra and I have 2 different viewpoints on that, and so we're going to have a quick little debate, and you can hear what our thought process is about it. What about ICD-10 and RA? How is that, what's the correlation between the two? Is there more to just RA than coding? And how much auditing is needed for RA work?
Turn everything back on. I was trying to get out of your way. So let's talk a little bit about history and explanation behind risk adjustment coding. I'm going to keep this very, very high level because it's something we go into in tremendous detail throughout the course. But the risk adjustment and where risk adjustment comes from. Risk adjustment was actually created to extend plans to those patients who had a little bit more difficulty getting health insurance. And we see that with the ACA marketplace plans, with the Medicare Advantage plans, with certain Medicaid plans. It's all around getting them the coverage that they need. And the way that they do that, with the way that the plans are incentivized to offer health care to these patients, is there's an adjustment in the amount that they're getting paid to help compensate for all of those different chronic conditions and illnesses that a patient may have. Where did risk adjustment come from? Well, risk adjustment has been around, believe it or not, since the 1980s. It's not brand new. It's been around for many, many years, but it's becoming more popular, and we're seeing it impact more and more areas of healthcare. So you're probably asking, okay, which plans are risk adjustment plans? The biggest areas of risk adjustment plans include your Medicare Advantage plans, right? Your Part C managed care Medicare plans, however you want to think of those. Your Medicare prescription drug plans, your Medicaid managed care plans, and most of those use a system called CDPS, or Chronic Illness and Disability Payment System. And then we have the new ACA marketplace plans, known as those Obamacare plans, and those plans are based on risk adjustment as well. Why do you need to understand risk adjustment? Well, risk adjustment is growing tremendously. Approximately 30% of the Medicare patients we have out there are on a risk adjustment plan. That's a huge portion of our Medicare population when you think about how many of our of the national population are on Medicare or eligible for Medicare. So it's a very large number. And Medicare, the federal government, via the ACA, the Affordable Care Act, is very much pushing that risk adjustment types of services that we're seeing reported in risk adjustment are going to permeate into other plans over the next couple of years. They're expecting to see an increase in the number of risk adjustment components for all plans. How does risk adjustment differ from traditional coding? Now, I want to explain something real quick before I talk too much about how this differs. When we talk about risk adjustment, most risk adjustment coders, most of them, not all by any means, but most of them work for a health plan, either directly, working for someone like United Healthcare, Humanical Choice, someone who offers a managed care plan of some sort. And their job is twofold. They're reviewing claims from physicians to make sure that the documentation supports the diagnosis code submitted, but they're also trying to determine which documentation is best for submitting codes to CMS, the federal carrier, because that federal carrier determines how much that health plan is going to get paid to treat that patient next year. So when it talks about how the coding differs, in a physician's office, most of the time the emphasis is on CPT coding, right? We only care about diagnosis from a medical necessity perspective. Is it going to back up the CPT code that we reported? Because usually we're getting paid fee for service. From a risk adjustment perspective, yeah, we want it to support the services we rendered, but more importantly, we want to make sure that prevention methods are being put in place, that patients are receiving the screenings and the vaccines that they should to keep them healthy. We also want to make sure that we are managing their chronic illness as well. Their diabetes isn't getting worse and leading to other manifestations and worsening, and using all of that data to predict what kind of care that patient's going to need next year. So risk adjustment coding is quite a bit different as far as which codes you tend to pick up as opposed to physician office coding. Why is there an increase in the number of risk adjustment plans? Well, risk adjustment plans, remember, those health plans are being incentivized to offer care to patients who either before were underinsured or uninsured. And the goal here is to get more people covered and to ensure that we are able to pay for the services that patient needs next year as a health plan. This is actually a great slide to demonstrate this. This was provided by the Kaiser Family Foundation. If you're not familiar with Kaiser, Kaiser Permanente is one of the largest Medicare Advantage plans in the country, and the Kaiser Family Foundation, who owns Kaiser Permanente, puts out a lot of statistical data on Medicare managed care plans or Medicare Advantage plans. This simply shows you from 1999 to 2015 how many millions of Medicare patients are enrolled in one of these Medicare Advantage plans. And if you think that risk adjustment and Medicare managed care is not on the rise, I kind of beg to differ. The statistics speak for themselves. It's increased, the number of patients, Medicare patients on a managed care plan has increased almost 10 million individuals over that 15-year period. So it's something that we're just seeing continuing to increase and increase and increase. This is a question we get all the time. Why am I going to spend the money? Why am I going to get this extra credential? What good is it going to do me? Does it really make an impact in my salary? This is from the AAPC salary survey. When we start to look at this, you absolutely begin to see a bump in salary as you add credentials, especially when you go from having one credential to having two. Part of the reason for that is there are more doors that open for you with a second credential. There are more areas that you can then demonstrate proficiency in, and more employers that are open to you, if you will. And you'll notice there's still a bump, even if you go from 2 to 3. And as you add additional credentials, typically there's some sort of bump. It may not be as significant as that first bump, but there is a salary bump. Excuse me. And one of the things that we always encourage people is, talk to your employers before you even start a program, especially if it's for something that they're already doing, because they may work with you to help pay for part of the education. They may reimburse it at the end. Once you've completed it, successfully passed it, they may say, okay, then we'll give you some money towards that. And some people are simply adding additional credentials so that they can have a better opportunity with a different employer. And they want that, that additional door open. So that's all something to think about when you're thinking about getting these additional credentials.
I think kind of summing that up to what Chandra said earlier with her credentials, multiple credentials give you credibility. And so that carries weight. They know that you've taken the time to take a training to get the credential, and that you you know, it's not easy to pass those exams. Most people that are hiring coders understand that. So it sets you aside as a specialist.
Yeah, and you at least have that baseline knowledge, and they can work from there. They don't expect you to know everything just because you have that credential. But they expect you to have a certain level of baseline understanding that they can then build upon and help customize towards their specifics, just like a physician's office.
So it's always good to have multiple credentials. We would never encourage somebody to stop. If you want just one, that's fine. Nothing wrong with that. However, it's not, once you've got one, it's not that hard to add some of these other. You're already in training mode. You know how to pass an exam already, and so keep going.
Once you get a second one, then you want a third, and it just keeps going.
I probably should have talked about that one since this is yours also, and I know your voice is tired, so here you go.
All right. Common question we get is, does the CRC designation only include HCC risk adjustment coding, or only Medicare? Let me clarify something here. I hear a lot of people in the risk adjustment world still refer to it as, oh, I'm an HCC coder. Okay, that's great. If you work for a Medicare managed care plan, you probably are an HCC coder. HCC stands for Hierarchical Condition Categories, and that's simply what Medicare does, and actually what all of the plans do. They take diagnoses and they put them into groups, and they create a hierarchy that says, you know, if a patient has this disease and this disease, can we report both of them, or does one supersede the other? For example, if a patient has multiple types of cancer, oftentimes you only get to report the most severe, the most likely to require lots of treatment and that sort of thing as the highest one. That's the hierarchical part of it. But it's all part of risk adjustment. So that's something that I'm helping join in all of those that are trying to get the verbiage changed, and those of us that have been in HCC coding for years, that it's really, that's a misnomer. It's risk adjustment, because there are so many other plans than just Medicare now. When we started out with HCC coding, it was predominantly Medicare, and that's why we call it, oh, it's just HCC coding, that's what Medicare calls it. Well, that they call it HCC for their Part C plans. For the Part D prescription drug plans, it's called RX HCC, or their prescription drug hierarchical condition categories. Medicaid now has a risk adjustment for their managed care plans called CDPS, or chronic illness and disability payment system. And now those ACA marketplace plans, those Obamacare plans that are managed care, have what we call an HHS HCC, the HHS standing for Health and Human Services. The CRC certification exam actually expects you to know a little bit about all of these. They expect you to know what the acronyms are for the different types, which ones are Medicare, which ones are Medicaid, which ones are the ACA marketplace plans, and what factors into each of those categories and how they differ. For example, the Medicare plans are going to be for predominantly your elderly and your disabled, right, that have certain conditions, all about that. Medicaid then expands that, because now you have children and other illnesses in there, and the marketplace plans expanded even further, because now you have those that may have an illness but not sick enough to lead them to Medicare or Medicaid coverage. So they all vary a little bit.
And you could be doing one, you know, hired to do CMS HCC work and be doing RX HCC work, and depending on who you work for. So again,
well, absolutely, because many of those, especially the Medicare managed care plans, have some form of prescription drug built into them or offered as an additional option. So many of the coders that work for a Medicare managed care plan do both. I should also point out Medicaid does also have a prescription drug component for theirs that's called an MRX, and that's something that we talk about in the course.
Well, this is one subject that I hear about all the time. Also, when I get calls from people wanting to know if risk adjustment is something that they want to get into, but they've had somebody say, oh, well, that's seasonal work, and you know, you may not want to get into risk adjustment. You might not work full time. there's a reason people say that, but actually it's not seasonal. Risk adjustment is done all year round. Now, the reason you may have heard that before is the fact that if you're a contract coder, and a lot of risk adjustment work is contract, they may only have a contract for a certain amount of charts per year, or there's actually 3 pulls a year. When I was originally hired to do risk adjustment coding for an MA plan, I was told from the beginning that if I was hired, that I might get laid off in November and December. Okay, because that's the way the contract worked for that MA plan. That it has happened in the past, so they like to let you know that it could happen. However, it's not seasonal. 3 pulls a year just tend to mean that that they hire coders, and the closer they get to the end when they need to do submission work, it's like a last minute, and sometimes there's this rush and you get a lot of overtime, and then all of a sudden there's less charts in the queue. I never got laid off. There was always a high demand for what we were doing, and not only is there 3 pulls a year, but and we'll talk about this a little bit later too, not all of the coders in risk adjustment stay for various reasons. Maybe they can't, hack the working remote. Maybe they don't like being audited all the time. Maybe it isn't their niche. And so there's several reasons that they start out with a lot, and sometimes some of these MA plans, and then they end up with an elite group, I guess you could say. So 3 pulls a year is why some people think that it's seasonal, which is again not true. That the MA plans work with contracts. They're taking contracts out. They're using contract coders a lot of the times. So you may work full-time, but you're self-employed, technically. And so that's the way MA plans. Now, there's other ways to work for risk adjustment that would be full-time, working for a facility or a physician group. Hiring policies, like I said, they let us know that those 2 months were the months that they usually had most of their contract fulfilled, and so you could be laid off. Technically, what happened when we got slow, they just moved us into doing other work, and so you got multi-trained. You were hired to do CMS HCC, and you ended up doing ESRD or doing some other work for contracts that they had. They've changed, though, in the past few years. I think that you need to be aware that now it's not just the MA plans, like Chandra mentioned before. It used to be predominantly CMS HCC codes that you were capturing, but now Medicaid risk adjusts, as well as those commercial plans that are reimbursed by the ACA. Okay, which is the Affordable Care Act or Obamacare. So when you have an insurance that's one of those metal plans, silver, gold, bronze, and platinum, all this other stuff, they risk adjust, and so the market's even bigger than it was before. So less likely that you would be laid off. It really has a lot to do with who your employer is, and so it's always a good idea when you're thinking about becoming a contractor or taking a job in a particular, with a particular group, kind of ask around, get a feel for them. You can do that on LinkedIn. You can there's plenty of mentors to say, yeah, that's a really good group, or, I haven't always heard that they have full-time year-round work. They just don't have a big enough contract. And now for that big debate I was telling you about. I guess since I'm on the left, I should give my point of view first. Chandra can follow up. Okay, she could follow up. I never was in debate class. However, we both have very valid points. I like to think of it like this. We come at risk adjustment from two different angles. Like Chandra said, her role had been working mostly for, not mostly, but predominantly a lot of the work she had been doing is the auditing aspect. She's going in and looking and educating about risk adjustment, that behind the scenes, why we do what we do, and so that's another viewpoint. Where my viewpoint is from what I like to call in the trenches coding. So I worked for an MA plan, and so therefore I was doing, well, it's not grunt work, but I like to think that Chandra was up here in the office and I was down here in the trenches. There's so many aspects of risk adjustment. So my point of view is that if you're going to do risk adjustment coding and you're doing charts all day long, you really have to have a firm foundation in coding, not just ICD-10. Now you need to really know ICD-10. And you need to enjoy diagnosis coding. I have to say, well, you have to love it, but when you're taking a course, another thing that it does is it allows you experience in both CPT and ICD. And I've done enough students through the years to say, I've got some that say, I absolutely love working with diagnoses. And then you have another group that says, I love CPT. Okay, so if you really love CPT and E&M work and stuff like that, well, then risk adjustment may not be a good fit for you, and you would learn that by taking a course. It's a lot of abstract work, abstracting the diagnosis, but not just the diagnosis. You need to be able to abstract a line. If a person states that they have, or if the document states that the patient has diabetes, but you cannot prove in that encounter that the patient's actively being treated by diabetes, and then, and pull out other little nuances and information about the condition, then you've got to be confident with your abstraction. The other thing is with risk adjustment, it's quality versus quantity. All right, people used to say way back in the day, why do inpatient coders get paid more? Well, it involves a lot more money, right? If you're working for a physician, you're dealing with a certain amount of money that's coming and going, that you're not really in charge of, but you understand that your coding makes a difference versus inpatient, and there's more documentation and so on and so forth. That's the same way it is with risk adjustment. We're talking about a lot of money, and they don't want you to make a mistake. So it's kind of an average. They tell you, with coding, I like to say standard coding, meaning all the other coding without, not risk adjustment, it's about a 95% accuracy rate when you're audited and everything. With risk adjustment, it's 98 or 99% accuracy rate, and you're constantly audited. Now, that's not an oppressive thing. It's a good thing because you're constantly learning. And so a person that's been coding or had a course and got their CPC, I feel like they've kind of been through all of this. They know what they're getting into, and so therefore they can go in with an open mind, and they're more flexible. Their knowledge base is just bigger. And now I'll turn it over to Chandra, and that she can attempt to explain why you don't need a CPC.
Thank you for being so gracious to not hog the floor. Yeah, thank you.
Well, the first thing I want to do, based on some of the chat questions, is clear up a little bit here. Risk adjustment coders do nothing with CPT codes. Right? Would you agree?
Yes, they don't touch them.
And the CPT codes are nowhere on the CRC exam. Neither are ICD-10 PCS codes. There are no procedure codes used when we're doing risk adjustment coding. Risk adjustment is based on diagnosis codes, and it involves, just as Alicia said, a very thorough understanding of the disease process, anatomy, pathophysiology, and how a disease evolves over time, especially if left untreated. What treatment measures are available, those types of things. But my perspective on this is that I think risk adjustment is actually a really good starting point for many, many individuals in the industry. Now, some people will say, well, certain employers won't hire you for risk adjustment unless you have a CPC or a CCA or either an AAPC or an AHEMA credential. I would say, okay, I understand that. The risk adjustment credential, the CRC, has only been around a little over a year. So it hasn't gained as much traction as some of the other credentials that have been there a lot longer. However, the more employers in the risk adjustment arena that learn about this credential and figure out how the testing is done, and that, wow, okay, they don't really, if you get someone who has a CPC, there's no guarantee that they really are comfortable with diagnosis coding. Not that they have to be able to diagnosis code. I'm not going to argue with that at all. And they have to have a baseline understanding of anatomy, med-term, that sort of thing. But there's no guarantee that they're really strong in diagnosis coding and disease process. The risk adjustment credential tests you more heavily from a coding perspective on diagnosis coding and disease process. So that's why I say, from my perspective, this is a great jumping off point for some people, because I've had a number of people come through my courses over the year, not just here at CCO, but when I taught at colleges in the past in different arenas. What you find is people either love CPT or they love ICD, one or the two. And I had a greater majority of those that once they really understood diagnosis coding and that condition was not a word you could look up in the index, that they understood it, and they're like, okay, this is easier. Well, it's easier, in my opinion, to begin to teach those individuals the disease process, how it evolves, and how diagnosis codes are related. But it requires a lot of the person getting into the field. They've got to be willing to ask questions. They've got to be receptive to constructive criticism. They've got to understand, just as Alicia said, that auditing aspect. You've got to be at a very, very, very high level of accuracy consistently. And I would agree that it is a quality over quantity, but that's for a set amount of time. The quality always stays there, but they do begin to push a quota the longer that you've been with any organization. So it's kind of one of those, for those that recognize it, I'm seeing a lot just via social media and all of the different job boards that we follow and all of that. There are more and more employers that are willing to hire certified individuals that have either a CPC or a CRC with little and sometimes even no experience to do risk adjustment, because there aren't any bad habits they have to break. They think, I can teach these people how to code exactly what I need them to code and how to interpret this documentation. And I will tell you, most employers, you go through a pretty rigorous training process. And it's just as Alicia said, it's there. You've kind of got a Bible, if you will, that you live by in addition to your code book, to help you clarify when you can code certain things and when you can't. And you're constantly audited and given feedback. And your audit results determine what you get in your queue the next day. That sort of thing. So that's kind of my perspective.
I add that in my opinion, if you're not certified and you're a clinician, the CRC is a great jump.
Absolutely.
Because you're already licensed, and so that's a really good step. So again, or even a transcriptionist, great transition. Yeah. So
Absolutely.
there you have both of our opinions.
Yeah, the more clinical knowledge you have, it's actually a benefit with the CRC. The only problem that I see typically with clinicians, and Alicia, I think you've probably seen this too, they have a very hard time shutting off their clinical mindset from actually writing down certain codes, right? They see the disease process and they know where it's going. Just because you know it's going there doesn't mean you can code that final code.
Right.
If the doctor didn't call it that. Right? Yeah. You've got to have all of the linking statements and the right information written in the chart, and that's where I see many, many clinicians, especially a lot of the nurses that I've worked with, they're like, that's just so hard. I know, I can see where the patient's going, and I'm like, and I get that, but you can only code what's in the record.
They overthink, and it's really hard to rein yourself back in when you have vast knowledge on something, and so some of them really struggle with that. But once they realize you do it, then it makes it easier. But they tend to do that. Well, I get the next slide. How exciting. What about ICD-10 in risk adjustment? I have to tell you, that's what it's all about. Just as Chandra said a minute ago, it's all about ICD-10, right? It's all about diagnosis. That's all you're doing is working with diagnosis codes. Now, not only are you only working with diagnosis codes, but you narrow it down into specific chronic conditions or specific illnesses if you're working with HHS and so on and so forth. So it's all about ICD-10, and you don't do any CPT at all. In fact, a lot of the encounters that you get are already coded, and you see the codes that they chose, but that's not what you're basing your coding on. You're looking at the encounter itself. You're not coding for the same person for the same purpose that the person already coded for. And with the EMR setups that we have now, where the physician is kind of picking the codes, again, you tend to code for a higher, an even higher specificity that's not often caught in the other coding. So it's all about the diagnosis coding. You know, when I did this slide, I wanted to put a big giant heart there, you know, a big red heart, because I love diagnosis coding, and then I decided, I should probably do some anatomy. It's all about anatomy in the disease process as well. So you have to stay on top of all of that. It is actually another language, right? You know, standard coding, you know, the CPC and other credentials, there's a language that you're translating, right? You're translating the documentation into codes. Well, with risk adjustment, you're doing that, but you're even tweaking it. They speak a little bit different language than standard coders, okay, because it's chronic conditions that they're looking at. They're capturing illnesses that risk adjust, that cost more money, that they need to set aside money in the coffer for next year because this person has diabetes and had a manifestation this year. So therefore, we know, et cetera, it could possibly happen. And if we don't set that money aside, then we won't have the money to treat that patient next year. It's all chronic diseases. That's the way you're thinking. So, you know, hypertension risk adjust. You think, well, that's chronic, but it actually doesn't carry a CMS HCC. It carries a risk RX HCC. So you have to think about those aspects of it. And now we're ready for Chandra. Is there more to risk adjustment than just coding?
Nah, not at all. Actually, the answer is quite the opposite. There is so much more to risk adjustment than just coding. You've got to understand, and when I'm talking about risk adjustment, working day-to-day as a risk adjustment coder, much of it is just coding, knowing the disease process, that sort of thing. But for the CRC exam, is that all you have to know? Absolutely not. And that's actually the experience that many experienced risk adjustment coders have had going into the exam. They think, I code day to day, I know the diagnosis and the disease process, I should be fine on the certification exam. If you actually look at the breakdown for the risk adjustment credential, only 60 questions out of the 150, so 40% of the exam, is diagnosis coding. Everything else is all of the other aspects of risk adjustment that you have to understand, such as what are the different risk adjustment plan types, like the Medicare and the Medicaid and the ACA marketplace plan, and what components factor into each of those. Is it patient age? Is it patient gender? In addition to the diagnosis codes, what about frailty, and is there a normalization factor, and all of these different pieces. You've got to understand record reviews and audits, prospective, retrospective, RADV, what the process is and why they do each of them, what the data submission requirements are, those 3 pulls that Alicia talked about. What are they done for? What's the health plan trying to submit to CMS? What information are they looking for? Right, they're looking for some of their best claims, and best claims are defined as those that support the classification that they're trying to get paid for. Understand how risk score calculations work, and know that the risk score calculation is different depending on the different type of risk adjustment plan you're looking at. Medicare's is different than Medicaid's, and Medicaid actually has different ones based on patient age and gender. And so do those ACA marketplace plans. Those are based on age and gender and metal level and all of these different pieces that factor into the risk score. And the risk score, if you're trying to figure out what that is, that determines how much that plan is going to get paid by their administrator, whether it be CMS or federal government, whoever it may be. Quality care impacts, STAR measures, and HEDIS, and how those quality care impacts are reported, how they're analyzed by the healthcare plan, and what impact they have on the payment that that health plan may receive, and what impact that the payment the healthcare plan receives, how that impacts the physicians who are submitting claims, right? Because this is a process, risk adjustment is a process where I kind of like to say it all rolls downhill, right? And the federal government's up at the top of the hill, and they have the money that they're going to pay. And it rolls down to the health plan based on the information they submitted, and they get a little bit of that pie, and they then have to use that money to pay the physicians who are down at the bottom of this pile. And it's all the physicians' documentation that drives all of this. And if the physicians, A, don't understand that, or B, don't have the documentation there that they need, they're going to see decreases in their fee schedules. They're going to see what we're calling narrowing networks. We're going to see more health plans dropping providers. There's lots and lots of need for documentation improvement, people with good communication skills. The picture down in the corner, you're probably like, what is that and why is that even there? I should probably preface this by saying I am the daughter of a mechanic, right? So my brain works in terms of cogs and gears and how it all comes together. This is actually a jet turbine, the inside cogs for a jet engine, if you will. And it's just showing how all of these different pieces kind of snap together to accomplish the same goal. If we don't have all of these different pieces and all of this different knowledge, A, we're not going to do well on the certification exam, but B, we're not going to be as good of a risk adjustment coder as we could be because maybe we don't see the full picture and understand how everything impacts the next step, right? One step impacts the next step that impacts the next step, and see how it actually all comes together and see that big picture. I think the next one's ready for you, Miss Alicia.
Oh, right. Someone asked in the chat, I noticed that real quick, and I think it kind of deals with this, do they look at just inpatient or outpatient charts? And
that's a great question. And the answer is they look at everything to a degree. I'm going to preface this by saying the documentation that is reviewed has to come from what they call an acceptable data source. And that is a list of inpatient environments, a list of outpatient environments, and a list of approved physician specialties. So it can be any one of those approved physicians on that list for any service performed in one of those outpatient or inpatient facilities or in the physician's office.
Right. And so you're looking at a year's worth of documentation on one patient, and every time they see a CMS-approved provider face-to-face, you will be coding off of it, likely.
So that chart for a year's worth of data could be 30 pages, or it could be 3,000 pages.
Yep. Just
depends on how much care that patient received last year.
Yeah.
Turn your camera on.
Oh, camera, yes, see my face. I just get so excited about getting to talk about it. How much auditing knowledge is needed for a risk adjustment coding? Well, actually, what do auditors do? They identify a problem, all right, and then they work to see how to fix it, or they suggest how to fix it. And I'm just going to see how many bullets I got here. The first thing that is important that's an auditing aspect is you have to understand the clinical documentation. So I think Chandra alluded earlier to that if you get hired to do risk adjustment work, that there's usually an in-house training process. The one that I went through was 6 months. Now, you get paid for that, but 6 months of training, before my training was over, I was released to submit straight to CMS, but I was still constantly audited, you know, and so they're looking for a mistake. That's not a bad thing. You embrace that, because once you make a mistake, you don't make that mistake again, because they give you a rationale. You can't link this code with this prescription, because this isn't really a prescription that's used for this diagnosis, or this treatment can be used with this diagnosis, etc. So there's an auditing aspect in the documentation that you learn. Then also you have to understand how the documentation works. So part of the job of what I did was to proof the encounter, to make sure that it met the standard for an approved document. And those are little things like, is there a valid electronic signature? We had a whole list of what was an accepted electronic signature and a not accepted electronic signature per CMS, and then per the MA plan that you worked for. Why do you have to do that? You have to audit it and look at that, because if that isn't a valid signature, you can't use that encounter at all, even if you found 4 diseases that risk adjust. So that is an auditing aspect. You have to know that the name of the patient has to be legible. They little things like that has to have an inpatient, an admit, and a discharge date. Little things that an auditor already looks at just automatically. When I'm teaching, doing going through an encounter and coding it, it's the risk adjustment coder in me always starts at the very bottom of the encounter and checks for the e-signature, and then I go and look at the diagnoses in the plan, and then I go up. And then you're looking at the whole header to make sure, does the doctor have a credential, et cetera, et cetera. These are all auditing steps for the documentation. Now, there's other types of auditing, but that's what risk adjustment auditing does. The disease process, again, you're auditing to make sure that that particular disease, the treatment that they picked to draw the line, is accurate. That the medication, that if they're on aspirin and they have hypertension, does that link? Or if they've had an MI but they're not on anything but aspirin, can that link? Yes. So you have to audit those steps. Also, just the format of the medical record. Like we said, you could pull a chart that has 30 pages, which sometimes were harder than the ones that had thousands, because most of that is not documentation that you can code off of. It's got all of the lab work, all the EKGs, and so on and so forth. But you have to understand all medical formats, all kinds of EHRs, because you're coding for the entire United States. You may be coding one day for somebody in New York and then somebody in the Boot Hill of Missouri the next. And so they don't use the same EMR. There is multiple EMRs. So sometimes, which really made the plan that I work for upset, is that the e-signature would be at the top. And it's just kind of an auditing rule that if the doctor signs off, nothing under it counts, right? He has to sign at the bottom. And so they had an EO, an error and omission code for that. And so, there was a lot of EMRs where the signature was up at the bottom. The doctor verified or electronically signed it there. Or where is the patient's birth date on this EMR? Where is the doctor's credential? Where are the diagnoses here? And where's the medications going to be? Is it going to be a list? Is there dates by the medication? Things like that. So you have to know multiple types of documentation and formats of records, not just for doctors, but for OT, PT, ST, right? Doctors sign off on those. Not nurses' notes, so you have to be able to tell the difference between a nurse's note and the physician making notes. Some of them won't let you do progress notes on inpatient. So all of those rules really boil down to auditing each individual encounter before you even get to abstracting the code. And that's what, honestly, a bulk of the training that you get when you're being trained in-house to do the records for a specific MA plan. That would happen probably a little faster and a little easier if you worked for one facility because you know their EMR and how those physicians wrote. You get to know them very well, so it would go faster. So auditing is a big part. It's not the same like you're trying to do E&M auditing. It's a different type of auditing, but it still is looking for errors and finding ways to improve and not make errors again. Oh, this is Chandra's. The wheel of risk adjustment. That's what I call it, not her.
I like that. It makes me think of a pizza.
Yeah.
So the question we had here is, will the CRC help you in other medical coding areas? This is an absolute great big bold print exclamation point yes. The skills that you need to pass the certification exam for the CRC and to really be successful in the risk adjustment arena are going to parlay into a lot of other areas. So communication. I'm going to start with communication. Communication is key across the board. Being able to communicate well both verbally as well as written is essential in healthcare. If you are not able to do that, you're going to tick a lot of people off, right? If you can't kind of communicate the way you need to through written language and take a lot of things into consideration. I don't know about you, but have you ever gotten that email that you just kind of interpreted incorrectly, or you interpreted like, well, why would they say that, right? We've got to be able to communicate. Much of our communication is done electronically, and we've got to be able to do electronic communication. We've got to be able to support our point of view. We've got to be able to fact check and do all of that, and that contributes across the board, regardless of which area of healthcare you're in, which certification exam you're trying to pass. Good communication skills are essential. Research. I am a big advocate of research. A lot of that probably has to do with the fact that I worked for an attorney and I have auditing background, right? That's what I'm beat into my head. Prove it, right? Where does it say, or what are you using to make the analysis that you're making? So you've got to be able to research and prove your point, be able to link drugs and diseases together, and be inquisitive, be willing to learn. In addition to that, you've got to have strong abstraction skills. You've got to be able to read through a record and, as Alicia said, be able to see that, oh, well, this patient is on hypertension and the provider refilled their lisinopril. Well, guess what? We dealt with that hypertension that day. Or they're a diabetic and they're on insulin and, oh, their past family social history says they had a pancreatectomy in 1999. Well, then we need to be clarifying, are they a diabetic because they don't have a pancreas anymore? Because the way we code that is a little bit different. There's a lot of information that goes into abstraction, and the stronger your abstraction skills are, the more likely it is that you're going to be able to find work in other areas like inpatient coding, right? Inpatient coding is predominantly abstraction, and you've got to be able to read through those records and do the analysis and figure out what things are related and what aren't. In addition to inpatient coding, clinical documentation improvement is all about being able to abstract and understanding the disease processes, pharmacology, pathophysiology, all of those pieces roll together. Disease process fundamentals. Understanding how a disease process works and how diagnoses are linked and what medications treat different conditions is going to make you stronger in any aspect of coding that you get into, quite frankly. Because coding is all about translating medical record documentation to a code, right? It's a foreign language translation for the most part. And the stronger that you are at understanding the disease process and the anatomy, pathophysiology, pharmacology, all of those aspects make you a stronger coder. And you can begin to figure out, oh, well, I wouldn't have realized those two are related if I didn't know about this disease process and if I hadn't looked into this. Quality measures. Now, for the purposes of risk adjustment, we talk predominantly about HEDIS and STAR. And if you're not familiar with HEDIS and STAR, you will be if you decide to take our course, or if you sit for the CRC, you have to learn about those. HEDIS is a national entity who sets quality measures. And the purpose of their quality measures is to allow for comparability from plan to plan. Did you or did you not make sure the patient had a screening mammogram? Did you or did you not assess the patient's body mass index? Those types of things. And those then parlay into the STAR measures for different health plans. They're ranked on how well they did at those HEDIS measures and a number of other areas, customer service, quality of care, those types of things, to get their STAR rating. And the STAR rating is just what we think about a STAR rating. Like if you booked a hotel, right? You want a 2-star hotel or you want a 5-star hotel? If you can afford it, you want the 5-star, right? If you can get a really good deal on it, I want the best one that money can buy. Works the same way with the health plans. As a patient, I want the highest star-rated plan I can afford or qualify for. And you find out not only how those quality measures work, but then other quality measures begin to make sense, like the physician reporting quality system, the PQRS, right? And meaningful use, and the EHR initiative, and the value-based modifier. And soon, coming soon to a world near all of us, MACRA and MIPS. If you have no idea what MACRA and MIPS are and you're planning on working in healthcare next year, go out and do a Google search. You're going to find out that risk adjustment is coming to all plans in some way or another, not just these Medicare Advantage plans. MACRA and MIPS is requiring us to do more reporting on diagnosis codes. And yes, it doesn't affect physician payment until 2019, but that is based on 2017 claims data. And we are rapidly approaching 2017. As well as overall structure. If you understand the overall structure of risk adjustment, you kind of have a big picture of how healthcare in general works, how everything is interrelated, how physician claims drive so much more than just physician reimbursement. They drive health plan reimbursement, they drive hospital reimbursement, they drive all of these different pieces. So as you begin to accumulate skills, it's very easy to extrapolate those to other areas in healthcare.
One of the things that I do for CCO as the educational director is I answer calls for people who are trying to find out if a course is good for them. This is what I'm interested in. Where should I start? What credentials should I start with? And they have questions. They've been talking and checking around schools. So here's some bullet points of things that I think you should consider. Are there testimonies from real students? We did see one time a testimony and found out it was obvious it was their employee, which, kind of biased, So real students, can I talk to previous students? And we have a Facebook page and other networks that you can talk to people that have actually been through our courses and passed, get their opinion. Is this credential a good fit for me? Again, maybe you're thinking that you want to get, you're a CPC, you want to get another credential, and you want to know, should I go to the CRC, or maybe I should go pick up the COC? Well, you need to have a discussion with somebody and let them fill out your background and kind of direct you in which way is probably a good way to go. Is the instructor certified? There is some courses out there where the instructor doesn't actually have the credential.
And let's say not just are they certified, but are they certified in the course they're teaching?
Yes.
Many people may have the CPC and they're teaching a CRC course, but they're not a CRC.
Right.
If you've sat through the exam, you have a much better understanding of what's included on that exam and are able to prepare your students a little bit better.
I would like to remind you what Chandra said earlier. There's only a small portion of the exam that's diagnosis coding, and so when I sat for it thinking that, hey, I'm this great risk adjustment coder and I love it, and I looked at that exam and I'm thinking, what's all this stuff? Now, luckily, I was familiar with it, but it wasn't what I expected, and so you want to have somebody that actually has done it to be able to give you that information. And what is? Go ahead.
The only other thing I was going to say is a lot of people have asked what's the difference between our risk adjustment course and the AAPC's course. Yes, we license many of the credentials through, or the credential programs and curriculum through AAPC. The risk adjustment is not one that they offer up for licensing, so we didn't have the opportunity to license their curriculum and use it in our courses. We had to develop our own. I believe that ours actually may be a little bit more robust than theirs and go into a little more detail because we want to prepare you not only to take the certification exam, but to be a good fit in risk adjustment, whether it's as a risk adjustment coder, working in risk adjustment administration, and answer a lot of the questions that nobody really answers for risk adjustment coders.
Right.
And to teach a course through the AAPC, if it's one that you license for them, if it were, and this is not one that they offer for license, but if it was, we would have to have that credential to teach it. So we kind of hold ourselves to that same standard. If we're going to let somebody coach for us or teach that class, they have to have that credential because it just makes good sense.
Right. Which leads into the next bullet point. What is their goal? Meaning, what's the school's goal? And that right there is our goal. We not only want to teach you about risk adjustment, we want to give you the information you need to pass the exam, and we would like to think that, we give you access for a year after you pass, come back and let us be subject matter experts when you have questions. So we really have a trifold kind of goal there. So make sure that their goal is to help you get certified. The college that I taught with, that was not their goal. Their goal was to give you college credits, and they didn't care if you passed the CPC or not, and so therefore that's when you pay $20,000, that's a little disillusioning when you can't get a job because you're not certified. What's covered in the course? And so with our pages, we have a whole list of what's in the course. Chandra did a video and broke down the difference between our previous course and the version 2.0 and how we streamlined that. So that's important. See what's actually in the course. How much does it cost? Very important. Find out how long does it take to complete the course. What's the average? And again, if you were to call and you say, well, I'm an RN, and I've been having to do diagnosis coding for a while. Well, that person's probably going to get through the course a little faster than somebody that says, I'm brand new to coding. So again, you want somebody not to tickle your ears. You want them to say, well, you're going to struggle with this. However, we've given you these tools to help you through. How long do I have access? It's not fun when they tell you it takes about 4 months to get through the course. We're going to give you 4 months, and then if you need more time, we're going to charge you every month. That's something you want to be aware of, and that's fine, because if you can get through in that amount of time, then that's good. That's another reason why we just give you full access for a year. Do I need to purchase books and manuals? Sometimes that's not included in the fee. We don't include books and manuals in most of our courses. You don't need a book for our CRC course because it's all written online, but you do need an ICD-10 manual. We don't make you get ours. We know that you probably already have one, so we don't include it in the course. Is there a guarantee? I have to tell you, in fact, Chandra may even remember, I had been looking at stuff, doing some research, and I came across this guy that was teaching this course, and he was guaranteeing people they would pass, or their money back for the exam. And I thought, wow, and I'm reading all of this stuff, and so I was like, hey, Chandra, look, have you ever heard of this guy? Well, she had, and she said, go back and look at the fine print. And so I did, and there were, the guarantee only went if you got like an 85% or greater on every chapter exam. If the practice exam that was required, you got a 95%, all these things, or they didn't guarantee it, and so, read, make sure, and it kind of goes down to the last bullet point. When somebody tells you something and it seems too good to be true, then it's probably not. And if people are trying to sell you something, they will tickle your ears and tell you what you want to hear. That's where you get back to the old coding, take a course online. You see them in magazines, and get your, take this course, make $60,000 a year, work from home. That's just not really a reality. So again,
give you that fine print that it might take you 5 years to get to that $60,000.
Yeah,
if you find a job, kind of thing. Yeah.
And so, again, we try to be very realistic. CCO does, where, if you say in the past, people used to say, well, I really want to work remote. Well, 5 years ago, it was really hard to work remote. You had to have at least 2 years under your belt, etc. Now, times have changed. So the advice or what I tell people isn't the same that I did back then, but I'm still very realistic. If you don't have a credential, you're probably not going to get hired. Can you get hired without a credential? Or if you've been working for a long time and you didn't need to get credentialed and you want to get credentialed, may you struggle with the course? Well, actually you might, because you've been doing, quote, real-world coding, and these are all in the guidelines and stuff. So, be aware that it might be a little harder than you think. We don't want to make it sound like this great, wonderful thing. I know our excitement comes across, but again, and I don't want to ever talk above your head and say, we're saying terms that you may not understand, but make sure that you're going to have a course that has somebody to coach you through and is able to answer questions, that give you feedback, and just go down through this list. I think it is just good advice. We also have a couple ebooks, I think 3 ebooks that you can ask us about, and later we can give you a link that can also guide you into what career path you want to go. Of course, I'm telling you, risk adjustment is awesome. It's a lot of fun.
So we've been talking about the CRC certification and our course, and this is the webinar sign up the sign up to purchase it. For a limited time, we're gonna just give you we've kind of already went over what is involved in choosing a course. And as we go to the next slide, and I'll put that link in the chat here as well. These are some of the things that are in the course that we're covering. And Chandra and Alicia, please go ahead and tell us a little bit more about what are specifically here.
Well, let me jump in real quick, because I know Chandra wants to talk about it, but I'm going to talk about it before her. The pearls, that's something that started with our original course, but these are amazing, and we just talked about them in the last Q&A webinar that we did a lot of information on risk adjustment, and they, I think, are going to help people. There's about 20, but there's about 20 more, and it's chronic conditions. Are we going to have about 40 total, Chandra?
We're going to have about 60 total.
60, okay.
Eventually.
So,
we're starting with 20. Let me preface that by saying we're starting with 20. We're going to keep adding after that point.
Right. So this is just a few of them. Again, chronic conditions, right? And it gives you really the inside outs about understanding the disease process and stuff. But I'll let Chandra talk about everything else, because she's the one that took the original course, streamlined it, and really built it into what it's going to be, which is exciting.
Okay, so we've been offering the version 1 risk adjustment course, as Alicia said, for a little over a year. It's made up of about 16 modules. Some of the modules are really short chapters, very, very short printouts, 15-minute lectures, really, really short. And what we did was we said, okay, there were some really robust areas and some really small areas, and many areas could have been combined and streamlined to better explain it in kind of a more logical fashion. So that's what we did, and we said, okay, we're going to break this down. We're going to have 7 modules. We're going to start out with an introduction to risk adjustment, where we talk about the history of risk adjustment, why we're talking about risk adjustment, where we're going with it, all of those pieces. Then we're going to spend time talking about the risk adjustment models and talk about the different versions, Medicare, Medicaid, ACA, all of those different pieces. Then we're going to go into coding for risk adjustment. This is by far one of the largest areas we have. We have an overall lecture, and then we have pearls and decision trees for almost every of our first 20 conditions that we have out there. And we will be adding lectures to go with those pearls over time. But we're trying to really get the pearls good and fine-tuned and well-used, and then use those to do our lectures. So that you've got some increase in content over time. When we talk about risk adjustment audits, we have one segment that's all about retrospective reviews and prospective reviews and the RADV audit process and all of how that data is submitted. A module all about documentation improvement, what the common errors that are seen in risk adjustment audits are, and how you communicate to your physicians, whether you work for a health plan or whether you work one-on-one with a physician. Then we do a module all about quality care impacts. Again, we focus on STAR and HEDIS measures. how those impact risk adjustment scores, healthcare plan ratings, all of that, and how it factors in. And then the bringing it all together is actually where we kind of recap from the beginning to the end, give you that overview of the whole system, and talk about how things are a little bit different from Medicare to Medicaid to ACA, how things kind of change. Even though you're in the same process, you're doing the same type of work, things can be a little bit different. We have lots of bonus material. There are some practice cases, and practice cases are different than practice encounters. Practice cases are short scenarios where a patient may have a couple chronic conditions and you're trying to code them correctly. Practice encounters are a full year of data on a single patient, and you're trying to capture all of the things that are reportable.
Do we have any CRC practice exams yet?
We do not yet have a CRC practice exam. It is coming. It is actually about half developed. We're working on getting the rest of it validated and up and together. So it's in the works. It's just not there yet.
And it will be added to the course, though.
Yep.
Yeah,
it will be added to the course. The one thing that I do want to point out that will come when we launch the course, instead of that free practice exam, there is actually a sample pre-employment exam. And the sample pre-employment exam is 30 questions, and it's not really a question. It lists out, here's the diagnosis the patient has, and you have to code it. And there's an answer key in both ICD-9 and ICD-10. For those of you who are not aware, many of the health plans right now are still using ICD-9 codes. And you're probably going, why? We went to I-10 in October. Well, the health plan's data that they have to submit to CMS is retrospective. It's based on last year's data determining their payment for next year. So last year, we were still in ICD-9 until October. So it's actually a culmination of both I-9 and I-10 codes. So you'll find our entire 2.0 course, our coding modules, our pearls include guidelines, indexing, and information on both ICD-9 and ICD-10 so that you have all the information that you need. And then we have decision trees for a number of areas that are covered in the ICD-10 coding guidelines. We wanted to break it down, make it a little bit easier to understand, make it a decision tree process. This is all version 2.0. I want to point out that in addition to this, you get access to the ICD-10-CM coding blitz that we do, which is a recap of all of the ICD-10-CM coding, as well as the RA blitz, the risk adjustment blitz that we put together, we talked about earlier. That's a recap.
Go back one slide and show them that, Alicia.
Sure.
I'm going to talk about our proven process. Is that okay?
Yeah, of course.
Yeah. So the reason that we include the blitzes is because this is what is part of what we call our proven process. We find that the most students that have success with us kind of have a three-tiered approach to preparing for the exam. They have sat for our course. So they attend our risk adjustment course, our HCC course. After they complete the course, then they sit through the blitz to review everything that they learned in the course and make sure that they understood everything correctly and that they've got that fresh in their minds. Then come the practice exams. That's why the practice exams aren't up yet, but they're coming very soon, so that we have a practice exam for you to go through. We find that if you do those three processes, typically you're very successful on your certification exam. You're as prepared as you could possibly be. With version 2.0, right now, if you were to purchase the course, we give you access to version 1 and version 2. And as we begin to migrate over to version 2, we're going to move a lot of the content that is in version 1 into the version 2 course. So you're not going to lose anything when we eventually get rid of version 1. It's going to move right into that version 2 course as it should, right? Version 2 is an upgrade from version 1. You want to get all of that same information. So we're going to move all of that over. You'll have access to the same lectures, which in some case means you can listen to the same topic twice by two different people with two different perspectives, because Alicia did all of the recordings for version 1 and I did most of the recordings for version 2. So you kind of get both of us.
And this is the again the link where you can go to get it, the Risk Adjustment 2.0 course contents, and we would greatly enjoy having you in our team. Also, one of the most important things is that it's not just a course, it's actually a community. and both of our coaches that we have here contribute to either being contacted by email or in our weekly support calls, which I believe right now Alicia is handling. You want to talk a little bit about our group calls, the support calls that we handle, and how our customers get that value from that?
We, like we mentioned before, we do give you access for a full year. It does not take very long to get through the course itself. I would say average 2 to 4 months, depending on your background and what your demands are, full-time work and so on. It doesn't take as long as the CPC course, put it that way. That being said, we give you a year because we know things happen, but we want to be your subject matter experts. And one of the ways that we help you have that community feel is every week we have a student webinar that is geared towards ICD-10, risk adjustment coding, and eventually the inpatient coding, because we'll be adding that in the near future. But it all is kind of based around ICD-10. They're all kind of married together there. And so those live events are exclusive to our students. Later in the replay club and some other ways you'll be able to kind of access that content. It is recorded and transcribed so that as a full-time student you can also go back, and if you weren't able to make a particular Wednesday night, and especially if you wanted us to cover something specific, it's there for you to have access to. Again, that community feeling, after you've passed the CRC, you're out there working, and say it's been 6 months, and you have a scenario pop up or a question, let us know. We'll research it with you, and I'm sure it'll help other people. So again, that is something that we want to expand. I guess I could throw in here that, we do give you access for a year, but say that you just fall in love with having all this access and knowing that, when 2017 comes around, all of the updates are just automatically, if there's any updates or changes in ICD-10 or in risk adjustment, which always seems to change, all that information is loaded in free for you. So let's say you had access for a year and you say, I want to keep going. I want all of the perks. And so we can do a month to month, and it's relatively inexpensive. And I'm sorry, off the top of my head, I don't know how much that is, but again, it's like $29 a month or something like that. Just don't quote me on that price. So again, it's very affordable to stay in contact and have that community feel, and we'd like to hope that you would do that.
Awesome. And just about our support calls, we actually have 3 now every week, and they're being recorded and transcribed. So even if you can't make the call, you can always access those after the fact. So it's a lot of additional work on our part, but again, we're committed to making sure that our students are getting the value that they require from our courses. So
and the questions that you have make us better instructors too, I think. So.
Yeah, absolutely. Keeps your chops going, right?
Mm-hmm.
And if you are on the fence for any particular reason, you want to talk to maybe somebody about our course, we have a solution for you. You can actually visit our help desk or send an email to helpdesk@cco.us. You can also call us toll free at 877-225-0713, and I'll put that in the chat as well. Or you can visit our help desk at helpdesk.cco.us/support/home, and that's all on the home page of our site. So until then, any last words from you guys?
Well, I think it's obvious that we like what we do. That we, I think that's one thing that CCO is known for too, is that we're kind of passionate about coding, all the aspects of coding, but we also really enjoy teaching, and that comes across. So we hope it resonates with you, and that you choose us for your educational needs, because we can help you not only get certified, but stay certified with your CEUs.
And I think it comes across to a lot of the people. We had a lot of comments in the chat. This is awesome for a free webinar. We've learned so much. We really appreciate it. And I kind of want to tail on to what Alicia said. I hope that you understand that We do this because we have a passion for it. We like the industry. We see that there's lots of opportunities. We want to help other people get certified and get into those opportunities and enhance their own lives. So we just want to be part of that and help that out.
We're kind of known for giving a lot of stuff out free, though, aren't we? CCO is very generous. Laureen's very generous, let me tell you, with the giving free stuff, because she knows that once you get a taste of CCO and the warm fuzziness, that you'll probably want to keep coming back.
So thank you, Alicia, thank you, Chandra, and thank you everyone for attending our webinar today. And we really appreciate you coming out and supporting us. And until next time, happy CRC coding.
Thanks, Boyd. Thanks for making us look great.
Yeah, he does make us look a lot better than I do.